Hello, my name is Brian Holcomb and I'm a clinical pharmacist at Genlex Corporation. This presentation is about drug interactions, their timing, pharmacogenetic interplay, and tips for recognizing and preventing them in clinical practice. These are my disclosures. I'm an employee of Genlex Corporation and an adjunct faculty member at Washington State University College of Pharmacy. The learning objectives of this lecture are to examine the time component involved in drug interactions, to recognize the interplay between drugs and genetics, to identify a drug interaction in a patient that presents to you with a problem, and lastly, to predict a drug interaction in a patient that you want to prescribe for. Let's begin with genetics. We're going to talk about personalized medicine, where genetics fits into personalized medicine, and then focus in on a particular types of genetics, which is pharmacogenetics. So what is personalized medicine? Well, it's partly what we already do. We use patient characteristics such as age, weight, renal and hepatic function when we are dosing or checking the dose of a medication. Part of personalized medicine is using therapeutic drug monitoring. So when we look at levels of digoxin, dilantin, or vancomycin, we're personalizing the dose and frequency of those drugs around the measured blood levels. Monitoring pharmacodynamic response, such as a patient's vitals or INR, is a way that we can reactively adjust the dose of a medication and personalize therapy for them. An emerging way we can personalize medicine is through biophysiologic modeling, or system dynamics. This involves the use of certain biophysiologic markers and blood levels of the drug, combined with an understanding of how they work together in the body. That is all put into a software program that uses calculus to predict future doses of the medication or the frequency that it should be given at. This is being done by the Mayo Clinic for vancomycin and Aranesp, a drug used in patients with chronic kidney disease. Genetic testing is a very broad area of personalized medicine and includes testing for newborns, diagnostics, carrier status, predictive testing, pre-symptomatic testing, and pharmacogenetics, which is what we will focus on for the rest of the presentation. Now I want to transition into pharmacogenetics, and to do that I will pose this question. Is there a correlation between DNA and adverse drug events? This case will introduce why we are talking about pharmacogenetics and how it relates to drug interactions. Michael died from a seizure caused by chronic fluoxetine overdose. He had a common genetic defect, making him a CYP2D6 poor metabolizer. CYP2D6 is the major metabolizing pathway for fluoxetine. Michael's doctor said that had he known about this defect, he would have used a different medication or decreased the dose. Unfortunately, this problem is not isolated to just Michael. There's 2.2 million severe adverse drug reactions a year. It's the fourth leading cause of death in the U.S. There are 100,000 deaths a year due to properly prescribed medications and 80,000 deaths per year due to improperly prescribed medications. 6% of malpractice claims are because of adverse drug events. The good news is that 2/3 of those are considered preventable. That's why we are talking about this today, and I hope to provide you with new tools and processes for handling this problem so that we can do something about these adverse drug events, which are partly due to drug interactions. Prescribing without genetics, we are using the advertised dose. Now this does incorporate personalized medicine because we are looking at age, weight, renal function, and other patient characteristics to choose the dose. But adding genetics allows us to do what I've seen in the literature called as precision medicine. It lets us fine-tune that dose to the individual patient so that your patient may be getting the advertised dose, or they may be getting an increased dose, a decreased dose, or a different medication altogether, which is probably what Michael should have received. Pharmacogenetics itself is a vast area, but our focus will be on the testing of cytochromes. Cytochromes, or CYP450s, are genetically variable drug metabolizing enzymes that are highly concentrated in the liver, but also found in other tissues like the gut wall, brain, placenta, and testes. This illustration shows how drugs are metabolized. Once a drug is introduced to the circulation, it must pass through the liver, which biotransforms it into a more water-soluble metabolite, which can then be eliminated from the system. The enzymes that do this are the cytochromes. If this enzyme pathway is blocked for some reason, whether it's because of a disease, old age, or other drugs or genetic defects, then the drug will not be metabolized, or other pathways will pick up the metabolism but much more slowly, and the drug will begin to accumulate, leading to potential toxicities. Through a simple cheek swab, we can determine what genotype and therefore phenotype a patient has for a given cytochrome. When describing CYP2D6, 2C9, and 2C19, poor metabolizers have defective alleles and do not produce the enzyme. Intermediate metabolizers have one defective allele and will express the decreased enzyme relative to a normal metabolizer. Normal metabolizers have two good copies of the gene and will typically have a standard response to an advertised dose. Ultra-rapid metabolizers actually have an extra copy of the gene, sometimes as many as 13, allowing them to produce a lot more enzyme than a normal metabolizer. You see a lot of frequency data here, but what I find most striking is that out of 15,000 patients tested at Genlex, less than 25% of them were normal for all three of these major drug metabolizing enzymes at a given time. Another way to think about these phenotypes is with the sink and drain analogy. The sink represents your patient and the water flowing into the sink, the drug being prescribed. In order for drug to exit the sink, it must flow through one of these drains. A poor metabolizer shown on the far left has a very, very narrow drain. So, as you can imagine, drug flowing out of them will be very slow. Contrast that to an ultra-rapid metabolizer on the far right. Drug clearance will be very rapid in these patients, and in order to keep them at a therapeutic level, the dose may need to be increased or a different medication used. These are some of the many drugs that are metabolized by the most important pathways for drug metabolism. Together, these CYPs, along the top, metabolize over 80% of all hepatically cleared drugs. Many of these drug classes are those that you see every day in practice. The FDA recognizes the importance of enzyme variants and actually recommends that drug manufacturers do studies and include dosing information as it pertains to specific drug metabolizing phenotypes. This graph illustrates the direct cause and effect between the number of alleles in a patient and drug levels. Along the y-axis is nortriptyline levels, and the x-axis represents time. The top gray line shows us that a patient with two defective CYP2D6 alleles, or a poor metabolizer, will have the highest levels of nortriptyline. As you increase the number of functioning alleles, the amount of enzyme expressed in the patient is increased and drug levels are decreased. The bottom beige line depicts an ultra-rapid metabolizer with 13 copies of the functioning allele and the lowest level of nortriptyline. I like this graph because it sets us up for the next analogy. This was my first car. It was a Volkswagen Bug, and it looked a lot like this. It was an older car, a 73, and if I remember right, it had a lot of problems. Most of the problems, though, did not manifest until my brother inherited it as his first car, after hard driving by myself and my younger sister, of course. By the time he got it, the thing broke down pretty regularly, and we got into the habit of having it pushed or towed to the mechanic. Since none of us kids were very mechanically inclined, if a problem wasn't obvious, we would really rely on that mechanic to fix it. Occasionally the problem would be the throttle cable or the carburetor, and after several hours of working on it, the car would be fixed and we'd go pick it up. However, one time the car broke down and the mechanic called us just in time for us to get home from dropping it off. So within 30 minutes. It turned out that the only thing wrong with the car was that it was out of gas. You see, the gas gauge stopped working sometime during my sister's tenure of the car, and this added to the problem list of things that could be wrong with the car when it broke down. The moral of this story is that not having a working gas gauge is like not knowing what type of drug metabolizer your patient is. If there's a problem with a drug, we may begin to chase red herrings like the carburetor or throttle cable, when in fact the true problem lies with the amount of drug that is or isn't in the patient. These are some web resources that I encourage you to review in order to learn more about the CYP450 system and pharmacogenetics. Okay, we've talked about genetics. Now I want to transition into drug interactions. This will be somewhat of an overview for many of you, as we will start with basic terminology. A substrate is a compound that is metabolized by a given enzyme. An inhibitor slows down or stops the metabolism of a substrate by a given enzyme. Here are some classic inhibitors. An inducer speeds up the metabolism of a substrate or by a given enzyme. And here are some classic inducers. This is a diagram of inhibition. The substrate normally attaches to the enzyme for metabolism, but here the enzyme is being blocked by an inhibitor. Clinically, that is very similar to the patient being an intermediate or poor metabolizer. This diagram shows induction. The drug being prescribed actually sends a signal to the nucleus of the cell, programming it to increase production of the CYP450 enzyme, which is ultimately going to result in decreased levels of the substrate drug. Clinically, this is very similar to the patient being an ultra-rapid metabolizer. Okay, we've talked about genetics and interaction terminology. Now let's begin to put all this together with cases. For the purpose of this presentation, let's say there are 4 types of interactions. Type 1 is pharmacodynamic. Type 2, pharmacokinetic, that happens immediately. Type 3, pharmacokinetic, that happens in 1 to 5 days. And type 4, pharmacokinetic, that happens in several weeks. Although pharmacodynamic interactions are extremely important, we're going to cover them in another lecture in order to focus solely on these 3 types of pharmacokinetic interactions. Type 1, a pharmacokinetic intermediate interaction. You prescribe a new drug for your patient, and the levels are either higher or lower relative to your expectation. Here you see you prescribe the medication, and levels of the drug are higher than you expected. This could be because the patient's on an inhibitor, or they are an intermediate or poor metabolizer. Also, you could prescribe a medication and levels of the drug are lower than you expected. This could be because the patient's on an inducer, or because they're an ultra-rapid metabolizer. Let's do a case for each. This is an 80-year-old patient on over-the-counter chlorpheniramine, 4 milligrams, around the clock for runny nose. The following day, she reported being extremely confused. She was a CYP2D6 poor metabolizer. Chlorpheniramine levels are increased 200% in CYP2D6 poor metabolizers. She was instructed to stop chlorpheniramine, and 3 days later she called to say that she could think clearly again. So this is an example of chlorpheniramine being added to a patient who has 2 defective alleles for the gene and doesn't express the enzyme. That resulted in immediate increases in chlorpheniramine and the adverse drug event that the patient experienced. This is a 17-year-old patient. She was diagnosed with cyclic vomiting syndrome. She was prescribed amitriptyline 1/2 milligram per kilogram at bedtime for added GI pain relief. She was a CYP2D6 ultra-rapid metabolizer, and amitriptyline is a major substrate for this pathway. When you look at the up-to-date guidelines for this cyclic vomiting syndrome, It says that some patients will not respond to 1 milligram per kilogram per day and have a very low or undetectable levels of the drug in their system. They may require future dose increases to have a response. So by knowing that this patient is a rapid metabolizer and knowing that amitriptyline is a substrate for this enzyme, it allows us to predict the interaction, and now the clinician can anticipate needing to titrate to 1 milligram per kilogram or higher to achieve the therapeutic response. By not anticipating and knowing this, we run the risk of maybe saying the drug didn't work for the patient and it was a treatment failure. And when that happens, we may prematurely discontinue it and add another drug, or we may be prone to add a second drug in addition to the first drug and causing a prescribing cascade. The next type of pharmacokinetic interaction is those that happen in 1 to 5 days. You prescribe a new drug or discontinue an old one, and the levels of another drug the patient was receiving either increase or decrease. But the time component here is 1 to 5 days. So you add a medication. Another drug the patient was on, though, its levels begin to increase over 1 to 5 days. That's because the drug you added is inhibiting the other drug's metabolism. Or you stop a medication. When you stop a medication, if it was an inhibitor, levels of the other medication the patient was receiving begin to decrease because its metabolism is no longer being inhibited. And that takes 1 to 5 days for the drug's levels to decrease significantly. Again, let's do a case for each. This is a 62-year-old patient with chronic lymphocytic leukemia. He had a 3-day history of fatigue, dyspnea, fever, and cough. He was prescribed valproic acid, 1,500 milligrams daily, and admitted on the following medications. Admitted and the following medications were started: ceftriaxone, clarithromycin, voriconazole, codeine 25 milligrams 3 times a day for cough. On day 4, he was found unresponsive and sent to the ICU. He had rapid improvement with naloxone. So let's look at the image on the right and walk through what's going on here. Codeine is metabolized by 2 different enzymes, CYP3A4 to inactive metabolites and CYP2D6 to its active metabolite morphine. When clarithromycin and voriconazole were added, those both inhibit CYP3A4. So adding those drugs caused codeine levels to increase. But as codeine levels increased, it was shunted through CYP2D6. The patient happened to be a rapid metabolizer of CYP2D6. So all of codeine's metabolism got shunted through 2D6, which resulted in much higher levels of morphine than anticipated. When they measured the levels of morphine in this patient, he had 80 times the normal levels of morphine. He did recover after 2 days. Okay, here's an example of an inhibitor being removed from the patient. This is a 32-year-old heroin addict using for 10 years. He also had a history of marijuana use, cocaine, and tobacco use. He was enrolled in your substance abuse program, and his medications include methadone 80 milligrams a day and Wellbutrin 150 milligrams twice a day. He was not satisfied with his methadone treatment, and he was feeling anxious, almost like he could go out and relapse. Well, it wasn't clear if the anxiety was due to this his addiction and his needs and withdrawal symptoms, or if it was because of Wellbutrin, which has one of its side effects of anxiety. So Wellbutrin was stopped, and then several days later he relapsed on heroin. Turned out he was a CYP2D6 ultra-rapid metabolizer. So what do we know about this case? Well, we know that patients from a clinical study, we know that patients who are CYP2D6 ultra-rapid metabolizers are less satisfied with their methadone replacement therapy. Methadone is metabolized by several different enzymes, but one of them is CYP2D6. And so CYP2D6 rapid metabolizers may need increased doses of methadone to achieve their desired replacement therapy levels. So the patient's a rapid metabolizer. When Wellbutrin was being prescribed, it's actually an inhibitor. So that would boost the methadone levels to a certain degree. It would counteract this ultra-rapid metabolizer phenotype. But when Wellbutrin was stopped, the methadone levels would begin to fall because you're exposing that CYP2D6 ultra-rapid metabolizer phenotype. And as those levels fall, the patient has worsening relapse and ultimately ends up using heroin again. Next case is a pharmacokinetic interaction that happens in weeks. You prescribe a new drug or discontinue an old one, and the levels of another drug the patient was on either decrease or increase. So here you add the medication, and levels of another drug the patient was on begin to decrease. Now the difference here is that this begins to happen over several weeks. Or you stop a medication, and the levels of another drug the patient was on begin to slowly increase over several weeks. Again, let's do a case for each. This is a 25-year-old patient who gets pregnant 2 months after starting carbamazepine. She was using carbamazepine for bipolar mania. Her dose was carbamazepine 800 milligrams a day, and she was on a low-dose oral contraceptive. She did experience breakthrough bleeding, but did not mention this to the healthcare provider. So mechanistically, what's happening here is carbamazepine is an inducer of CYP3A4. The combined oral contraceptive is metabolized by CYP3A4. So as this induction takes time to happen, this carbamazepine sends a signal to the nucleus of the cell. The cell begins to upregulate this protein, this enzyme. And as that happens, these combined oral contraceptive levels begin to creep down, ultimately resulting in breakthrough bleeding and pregnancy. This is a screenshot of one of the software programs I'll show you. I'll show you more of these in a moment, but this is a screenshot of one of the software programs available to you. Here you see carbamazepine is causing a 31 to 50% decrease in levonorgestrel levels and a 31 to 50% decrease in ethinyl estradiol levels. Because the patient was on a low dose to begin with, this resulted in a loss of efficacy of the medication and treatment failure. Here's a case. This patient suffered from reversible respiratory depression, was receiving methadone 120 milligrams a day for chronic pain management due to advanced lung cancer and dorsal lumbar bone metastases. He was prescribed gabapentin 900 milligrams a day for neuropathic pain. 11 days earlier, carbamazepine 1200 milligrams a day for neuropathic pain was stopped due to ataxia. The methadone dose was not adjusted. So what's happening here is that methadone, again, is a substrate for multiple pathways, 3A4, 2D6, and 2B6. Carbamazepine, as we saw in the first case, is an inducer, the last case, the pregnancy case, is a inducer of CYP3A4. So when carbamazepine was stopped, its induction signal was stopped. And methadone's levels began to slowly increase and creep up because that 3A4, the amount of 3A4 being expressed, began to decrease. As that happened, the patient began having much higher levels of methadone than intended, and then respiratory depression. It's likely here that the patient's pain got out of control and the methadone dose was actually increased to account for that, resulting in this sort of unexpected overload of opioid in the patient's system. Fortunately, the patient did improve with naloxone. Okay, let's tie this all together now. And let's go through an example of where we'll identify an interaction in a patient that's presenting to you with a problem, or predict an interaction in a patient that you want to prescribe for. So a patient presents to you with what you suspect is an adverse drug event. You want to know if it's a result of a drug interaction or a genetic interaction, a genetic defect, or an extra copy of an allele. You're doing this because you want to narrow your differential. You look at the drugs that were added or removed, and the thing I want you to remember is to look at least 3 weeks back. And to do this, it's really important to use a drug interaction software to see if the combination that you are seeing that was added or removed correlates to the suspected adverse drug effect. You can also call your pharmacist to help you with this, and then make the appropriate changes. Here, you will predict an interaction in a patient that you want to prescribe for. These are the steps to use. You want to know if the drug you're going to add or stop is going to cause a problem. So you examine the medication you are prescribing or stopping against the patient or medication, against the patient's other medications. Remember to not only look for immediate and delayed problems, but for problems that may arise 3 weeks out. Use a drug interaction software program, and then make the appropriate change. Using discrete mathematics, I put together this equation. Actually, I didn't do it. My brother, who, although he's not mechanically inclined, he's very good at math, put this together for me. And this simple graph shows that as the number of medications are increased, the number of potential types of interactions increased. So assuming that there's 4 types of interactions, pharmacodynamic, pharmacokinetic immediate, pharmacokinetic 1 to 5 days, and pharmacokinetic weeks, if you look at the possible number of combinations of those interactions, by the time you have a patient on 15 medications, there's 420 different types of interactions that could result as a result of those drug pairings. And that's a tremendous amount of interactions to have to remember, and really impossible for anyone to do. And you can see as you add medications, that increase happens exponentially. So that's why it's so important to use software to help identify these interactions. And that's what this slide is here for, is to show you some of the available interaction tools to use to identify these potential problems. Let's finish with some clinical take-home points. Just because the patient has been on or off a drug for 3 weeks doesn't mean that it's not the problem. Genetics are just as important as other drugs for interactions. There is a complex interplay between drugs and genetics, and there are just too many interactions to rely on our own memory. Software is essential for identifying and predicting them. Thank you so much. That concludes this presentation. Here are some recommended readings and references. If you'll now go to the Ohio Northern University website, you can take the post quiz in order to achieve your CE credits.